manifestation of Ramsay-Hunt syndrome except one. Which one is the exception? Deafness, ocular keratitis, facial paralysis, or vertigo. Now, before we can discuss which is not a manifestation of Ramsay-Hunt syndrome, let's discuss what this syndrome is. Ramsay-Hunt syndrome is also known as herpes zoster oticus, and it is what occurs when shingles affects one of your facial nerves and vestibulocochlear nerves. Now let's talk just a little bit about shingles itself before we only talk about what occurs when it affects the facial and vestibulocochlear nerve. Herpes zoster or shingles occurs in 10 to 20% of the population who have been infected with the varicella zoster virus or chickenpox, with an increased frequency seen as a patient gets older. It is a reactivation of the same virus that originally caused chickenpox in a patient that had remained dormant in the body for years before eventually reactivating to cause symptoms. Shingles is characterized by painful erythema and vesicle syndrome. Let's discuss what this syndrome is. Ramsay-Hunt syndrome is also known as herpes zoster oticus, and it is what occurs when shingles affects one of your facial nerves and vestibulocochlear nerves. Now let's talk just a little bit about shingles itself before we only talk about what occurs when it affects the facial and vestibulocochlear nerve. Herpes zoster or shingles occurs in 10 to 20% of the population who have been infected with the varicella zoster virus or chickenpox, with an increased frequency seen as a patient gets older. It is a reactivation of the same virus that originally caused chickenpox in a patient that had remained dormant in the body for years before eventually reactivating to cause symptoms. Shingles is characterized by painful erythema and vesicles, usually on the trunk or head and neck region. Other symptoms include burning or shooting pain, tingling or itching, while some people also experience fever, headache, and chills. A characteristic feature of shingles is that the lesions characteristically stop at the midline of the body. This is because the virus travels along a certain dermatome or area of skin innervated by a single spinal nerve dorsal root. Treatment for this condition is systemic acyclovir if early in the course of the disease, and it has a good prognosis, with the lesions resolving in about 2 to 3 weeks. As far as Ramsay-Hunt syndrome specifically, it is reactivation of this varicella zoster virus along the facial nerve, or cranial nerve 7, and the vestibulocochlear nerve, or cranial nerve 8. The facial nerve is mainly responsible for motor innervation to the muscles of facial expression, and the vestibulocochlear nerve is responsible for hearing, as well as being involved with balance, spatial sensation, and posture. In addition to the characteristic shingles rash, infection of these nerves can cause unilateral facial paralysis, facial weakness, hearing loss, ear pain, tinnitus, difficulty closing the eye and dry eyes, and even vertigo. Prompt treatment is important for this condition to help prevent permanent hearing loss, eye damage, or facial weakness. Treatment includes the same medications mentioned earlier for a typical shingles infection, such as acyclovir, but can also include other palliative medications to specifically treat the symptoms. Based on everything we've said about this condition, we know the correct answer, or the answer choice that is not a manifestation of Ramsay-Hunt syndrome, would be B, ocular keratitis. Ocular keratitis describes inflammation of the cornea that can be due to an infection or minor trauma to the eye, such as getting a foreign body stuck. Although Ramsay-Hunt syndrome can cause pain to the eye, this is due to the inability to close the eye from facial paralysis, leading to an overly dry and irritated eye. This condition does not lead to inflammation of the cornea, and that is why it is not a manifestation of this syndrome. Now let's go through the other answer choices and re-emphasize that they are indeed common manifestations of Ramsay-Hunt syndrome. And we'll start with deafness. This is definitely a common manifestation of this syndrome, and it's due to the reactivated virus infecting the vestibulocochlear nerve, which is responsible for hearing. This deafness is usually partial and tends to go away once the infection is resolved, but it is certainly a manifestation of Ramsay-Hunt syndrome and would therefore be an incorrect answer. Next, we have facial paralysis. This is probably the most common manifestation of this syndrome, and it's due to the reactivated virus infecting the facial nerve, which is responsible for motor innervation to the muscles of facial expression. Without this innervation, the facial muscles suffer unilateral paralysis and lead to facial drooping and difficulty closing the eye. This is definitely an incorrect answer choice. And then finally, we have vertigo. This is another manifestation that would be the result of the vestibulocochlear nerve being infected by that reactivated virus. Beyond just hearing, this cranial nerve is also responsible for vestibular functions like balance and posture, and an impairment in these functions can definitely cause spinning or dizziness, known as vertigo. Because vertigo is a common manifestation of the syndrome, we know this answer choice is also incorrect. So when discussing Ramsay-Hunt syndrome, which is due to the herpes zoster virus infecting the facial and vestibulocochlear nerves, we know that deafness, facial paralysis, and vertigo are all common manifestations, while ocular keratitis is not. This question is asking, ketone bodies are most likely formed due to the lack of glucose, fatty acids, amino acids, or glycerol. Now, to answer this question, you need to know what ketone bodies are and when they can become a concern, such as in ketoacidosis, which is also known as diabetic ketoacidosis. Now, this condition occurs when the body does not produce enough insulin. Insulin is a major anabolic hormone that allows glucose to be transported and stored in cells within the body after meals. If glucose is unable to be transported and stored, the body is unable to use it as an energy source for the body. And when this is the case, the body will have to turn to other sources of energy, and it will tell the liver to break down fats into ketones for the body to use. These ketones or ketone bodies are acids, and they will build up in the bloodstream and cause this ketoacidosis. Keto just referring to the ketones that are a byproduct of those fats, and acidosis referring to the acidic level of the blood that results. This is a condition that often comes on very suddenly, even within 24 hours. Symptoms of ketoacidosis include being very thirsty, increased urination, nausea or feeling the need to vomit, confusion, fruity smelling breath, fatigue, and stomach pain. The good thing about ketoacidosis is that it can usually be prevented by ensuring that a patient's insulin levels are well controlled. Now, based on everything we just said about ketoacidosis and ketone bodies, we know that they are most likely formed due to the lack of glucose. So, although we said that not enough insulin is being produced when ketoacidosis occurs, which makes sense since this mainly occurs in diabetics, this lack of insulin leads to a lack of glucose being available, and the body is turning to other energy sources. Without insulin, you don't have proper regulation and storage and control of glucose. So you'll have a lack of glucose lead to these ketone bodies being formed as the body is turning to other energy sources. So these ketone bodies are formed as byproducts when the body does not have enough glucose and has to resort to breaking down fats instead. Now, I do want to point out that although ketoacidosis mostly occurs in diabetics, ketone bodies can be produced in patients who do not have diabetes. Ketoacidosis only occurs when an extreme amount are produced, but some of these bodies can be produced without getting to that extent. In a non-diabetic patient, these may be produced when a person is fasting, during prolonged exercise, or is in a very low-carb diet, which is often commonly called a keto. You've probably heard of a keto diet. It's referring to these ketone bodies. So it all makes sense when you think about it. Now, either way, the production of these ketone bodies is always due to the lack of glucose. So we know that this is the correct answer choice. Now, let's still go over the other answer choices and discuss why they are incorrect here. We'll start with fatty acids. Now, this answer choice is definitely incorrect, as it is basically the opposite of the truth. Fatty acids are actually what is used to produce ketone bodies. They are the alternate fuel that is used when glucose is not available. A lack of fatty acids would prevent these ketone bodies from being produced at all. But what are fatty acids? These are the main components of lipids, and they play a crucial role in energy storage, cellular structure, and metabolic processes. These fatty acids can be saturated, unsaturated, or trans fats, which I'm sure you've heard of, and they come from a variety of food sources. So because these are the production source for ketone bodies, a lack of them would not lead to their production, making this answer choice incorrect. Next, we have amino acids, which I'm sure you're familiar with. They're known as the building blocks of proteins. There are 20 different amino acids, some which can be synthesized by the body, and others which have to be obtained from the diet. Beyond protein synthesis, these amino acids also play roles in the metabolism, neurotransmitter synthesis, hormone production, and immune function. Now, although amino acids can be used for energy during prolonged periods of starvation, just like fatty acids, a lack of them would have nothing to do with the production of these ketone bodies. A lack of amino acids would instead lead to protein malnutritions or deficiencies, but would not cause these ketone bodies to be produced, making this answer choice incorrect. And then finally, we have glycerol. In case you were unfamiliar with glycerol, it's a key component in triglycerides and phospholipids, and it can also be converted into glucose in the liver to maintain blood sugar levels. So that may have thrown you off a little bit, but it mainly serves roles in fat storage and energy production. So while glycerol itself isn't used to directly produce ketone bodies, it does play an important role in energy metabolism, particularly when glucose is not available. However, a lack of glycerol wouldn't affect ketone body production directly. Ketone bodies are produced only from fatty acids when glucose is lacking, not from glycerol. If glycerol is lacking, you still have enough glucose to be able to be used as an energy source. If you're lacking glucose, you might use glycerol as a backup, but a lack of glycerol would not form these ketone bodies, making this answer choice incorrect. So we know that when talking about ketone bodies, they are most likely formed due to the lack of glucose in the body and not a lack of fatty acids, amino acids, or glycerol. We have a 7-year-old female who says, "I'm having pain at my extraction site. She has scleroderma, and her upper right first molar was extracted 1 week ago. She's taking aspirin, and we notice a normal healing process. And we're asked which is commonly associated with this condition." Now, this question is testing our knowledge concerning the patient's condition, which we know is scleroderma from the patient box. Before we decide which of these answer choices is correct, let's first talk about what scleroderma is. This condition is also known as systemic sclerosis and is a relatively rare immune-mediated condition characterized by inappropriate deposition of dense collagen. It is called scleroderma because sclero means hard and derma means skin, and it's also 3 times as common in women. Clinically, this condition is characterized by diffuse, hard, smooth skin, the Raynaud phenomenon, sclerodactyly, acroosteolysis, a mask-like face, a pinched appearance of the nose, microstomia or a small opening of the mouth, and difficulty swallowing. Now, that's a lot of terminology that we just said, so let's break some of it down. Raynaud's phenomenon is the discoloration or whiteness of the fingers and or toes after exposure to changes in temperature or emotional events, and it causes the spasm of the blood vessels. Sclerodactyly is a claw-like deformity of the fingers due to the collagen deposition, while acroosteolysis is destruction of the digit tips, including the bone, and you can see both of these findings in this image. Other symptoms of this condition include pulmonary, renal, cardiac, and GI temperature or emotional events, and it causes the hard, smooth skin, the Raynaud phenomenon of dense collagen. It is called scleroderma because sclero means hard and derma means skin, and it's also 3 times as common in women. Clinically, this condition is characterized by diffuse, hard, smooth skin, the Raynaud phenomenon, sclerodactyly, acroosteolysis, a mask-like face, a pinched appearance of the nose, microstomia or a small opening of the mouth, and difficulty swallowing. Now that's a lot of terminology that we just said, so let's break some of it down. Raynaud's phenomenon is the discoloration or whiteness of the fingers and or toes after exposure to changes in temperature or emotional events, and it causes the spasm of the blood vessels. Sclerodactyly is a claw-like deformity of the fingers due to the collagen deposition, while acroosteolysis is destruction of the digit tips, including the bone, and you can see both of these findings in this image. Other symptoms of this condition include pulmonary, renal, cardiac, and GI fibrosis. Radiographically, this condition presents with diffuse widening of the periodontal ligament, resorption of the posterior ramus condyle coronoid process or chin, and sometimes root resorption as well. Treatment for this condition is difficult and is mainly targeted at treating the symptoms. The prognosis for this condition is poor as death occurs due to the internal organ deposition of collagen, with most deaths due to pulmonary involvement. So looking back at the question being asked, we should know which answer choice is correct. That would be A. Scleroderma is commonly associated with enlarged radiographic lamina dura space, which is due to thickening of the periodontal ligament. Now, although we know this is the correct answer choice, let's quickly go through the other answer choices and discuss why they would be incorrect. We'll start with B, a constricted radiographic lamina dura space. This answer choice is incorrect because it's the exact opposite of what we see in scleroderma. We see widening or enlargement of the lamina dura. We definitely don't see constriction. If we think about this answer choice and what we know causes scleroderma, it doesn't make any sense. Scleroderma is due to an excess of collagen deposition. We know the periodontal ligaments that are present in the lamina dura space are made of collagen, so more collagen in this area would logically result in the space widening, not constricting. And because of that, this answer choice would be incorrect. Next, we have osteoma formation in the jaws. This answer choice is incorrect because this is not a finding seen in scleroderma, but is actually a finding seen in another condition known as Gardner's syndrome. This is an uncommon autosomal dominant polyposis syndrome that is highly penetrant. Clinically, it's characterized by multiple osteomas, which we can see in this image, epidermoid cysts, desmoid tumors, and most significantly, the development of precancerous polyps of the colon. These intestinal polyps develop by the second decade and ultimately transform to adenocarcinomas. This syndrome also has dental effects, which include impacted teeth, the presence of supernumerary teeth, and odontomas. Treatment for this syndrome includes prophylactic colectomy, removal of cosmetically problematic cysts and osteomas, and genetic counseling. And the prognosis is guarded due to the development of adenocarcinomas. Because osteomas or benign bone tumors are commonly associated with this syndrome, Gardner syndrome, and not scleroderma, we know this answer choice is incorrect. And then finally, we have delayed healing of extraction sites. Now, this answer choice may have been a little tricky because our patient's chief complaint was that she was having pain at her extraction site. But we were also told that she currently has a normal healing process. And this is because scleroderma is not associated with delayed healing. Delayed healing is associated with a lot of conditions and local findings, such as diabetes or the presence of an infection. But because the deposition of collagen seen in scleroderma has no effect on extraction site healing, we know this answer choice is incorrect. So we know that when we're talking about scleroderma, the deposition of dense collagen results in an enlarged radiographic lamina dura space. This question is asking, each of the following anomalies can be caused by defects during the initiation stage of tooth development except one. Which one is the exception? Hypodontia, macrodontia, anodontia, or hyperdontia. So 3 of these are due to a defect during that initiation stage and 1 is not. So before we talk about each of these, let's talk about that initiation stage. So tooth development as a whole, or odontogenesis, has 6 stages, with the initiation stage being that first stage. Now this occurs at 6 weeks in utero and involves the oral epithelium proliferating into the ectomesenchyme to form the primary epithelial band or the dental lamina. Now initiation, like the name implies, is the first step of forming the structures that go on to become the teeth. Now, if these structures don't initiate or too many initiate, the number of teeth formed as a result can be affected. So an important trend to know for odontogenesis is that the earlier in the process a defect occurs, the more detrimental the effects will be. So if there's a problem earlier on in the process, we're going to have more detrimental effects to the tooth. So if there's a defect in that first stage, that initiation stage, then we could have a tooth just not form at all. But if we have a defect in, say, the last stage or a later stage in general, you could just result in thin and weak enamel in a tooth that has mostly formed. So that's an important trend to kind of know. Let's focus in on this question. And I want to say, if we look at these answer choices, they look very similar. So the prefixes of these words are very important. All of the suffixes of the words are the same. They're dontia, they just mean tooth. So you really need to focus in on these specific prefixes to determine what the answer is. So the correct answer here, the one that is not caused by a defect during the initiation stage of tooth development, would be B, macrodontia. So macro just means large, and this is unusually large teeth. That's what we're seeing here. Now this is not very common, and it's way less common than its opposite, which would be microdontia, or small teeth. So macro means large, micro means small, and dontia just means tooth. Now this is associated with various syndromes and systemic diseases, and this is due to a defect in the bud stage, which is the second stage of odontogenesis. So this is not due to a defect in initiation stage, which is that first stage. This is due to a defect in the bud stage, which is the second stage of odontogenesis, which occurs at 8 weeks. But let's go through these other answer choices and just talk about at least what they are, even though they are all caused by defects during the initiation stage of tooth development. So we'll start with hypodontia. Now hypo, the prefix means less than normal, and it's a reduced number of teeth. So this is most commonly seen as a dental developmental anomaly. Out of these answer choices, this is pretty common, but it's uncommon in the deciduous dentition. So we normally see this in the permanent dentition. Now this can have a genetic or environmental etiology, and it most often affects the third molars, the second premolars, and those maxillary lateral incisors. So that's where we normally see this hypodontia. These are the teeth that are usually missing. Now a defect in the initiation stage leads to this occurring. So it leads to the less of those tooth structures originally being formed, so we don't get these full teeth that end up erupting. Now let's go ahead and talk about anodontia. Now an, that prefix an, means not or without. So this would be a complete absence of teeth. So someone who has anodontia has no teeth. And a defect in the initiation stage leads to none of those tooth structures being formed. So there's obviously a big defect because none of these tooth structures are being formed. Maybe odontogenesis didn't even occur, so we have no teeth. So anodontia means no teeth, and this is the complete absence of teeth. And finally, hyperdontia, hyper means excessive, and is the presence of supernumerary teeth or extra teeth. So hyper, we're having more teeth than is normally seen in the mouth, so more than that 32. Now this occurs in 1 to 3% of the population and is more frequent in the permanent dentition than the deciduous dentition, just like we saw for hypodontia. Now 95% of the time this occurs in the maxilla, usually anteriorly, with the most common supernumerary tooth being the mesiodens. So that's when you have an extra tooth right in between your central incisors. So that's what a mesiodens is. Now these additional teeth may affect your occlusion, they may affect your hygiene, be difficult to clean, and they may be unaesthetic to some people, so we might remove them if they're not wanted or if they're causing problems. So this is caused by, once again, a defect in the initiation stage, just like we said, and this leads to an excess number of those tooth structures being formed. So we're having more of this odontogenesis occurring, more tooth structures that will go on to become teeth. That's what we're seeing in hyperdontia. But out of all these answer choices, it's important to remember that macrodontia is a defect in the bud stage. It's not a defect during the initiation stage. It doesn't affect the number of teeth that are occurring. So all these other ones, hypodontia is reduced number of teeth, anodontia is no teeth, and hyperdontia is more teeth. So those are all concerning the quantity of teeth that we have, while macrodontia is affecting the tooth size. So keep that in mind, that it's not a defect during the initiation stage of tooth development, and you'll be able to answer this question. We have a male, he's 28 years old, and he's here for a checkup. He has a 3-pack year smoking history, we're given his BMI, his blood pressure, and we notice a swelling in the back of the mouth that's asymptomatic and less than 1 centimeter in diameter. It's sessile upon palpation, and there's no radiographic findings. And we're given this image to look at to make our diagnosis. And we're asked which abnormality is indicated in the image. Now we're given a very thorough description of this lesion and even have an image to look at when making this diagnosis, so it should be pretty straightforward. The first hint that we're given is the location of this lesion. This reddish yellow lesion, we can see in the image that this lesion is located back by the tonsillar pillars. And this location is a big clue because certain lesions are more common in certain areas. Some important information given to us in the patient box is the fact that it's asymptomatic and less than 1 centimeter in diameter. The correct diagnosis for this lesion is typically asymptomatic and associated with that exact size. A final important clue is the fact that there are no radiographic findings. This indicates that this lesion is only found in the soft tissue and does not impact the underlying bone. Due to all this information and the helpful image given, we know that this patient has B, a lymphoepithelial cyst. Now, oral lymphoepithelial cysts are uncommon developmental soft tissue cysts that arise in oral lymphoid tissue. They're common in children and are thought to be due to entrapment of the surface epithelium during embryogenesis within a lymphoid aggregate. These cysts are commonly located in Waldeyer's tonsillar ring, which is the location we see it in our patient. They're also commonly seen on the floor of the mouth or the lateral aspect of the tongue. Clinically, these present as yellowish, red, white, submucosal nodules with a smooth surface that are typically 1 centimeter or less in size, as we saw in the patient box for this lesion. They're sessile and typically asymptomatic, but may be tender or drained periodically. The contents of the cyst can vary from a cheesy to a creamy white material upon drainage or excision. A final thing to point out is because this is a soft tissue cyst, there are no radiographic findings. Now, if these are diagnosed and are asymptomatic, then they may be periodically monitored rather than treated, but they are treated via conservative surgical excision if the diagnosis is uncertain or the lesion is symptomatic. Now let's go through the other answer choices and talk about what they are and how they're similar and different from oral lymphoepithelial cysts. We'll start with a lipoma, or the lesion is symptomatic rather than treated, but they are treated via conservative surgical excision if the diagnosis is uncertain or the lesion is symptomatic. Now let's go through the other answer choices and talk about what they are and how they're similar and different from oral lymphoepithelial cysts. We'll start with a lipoma. Now this is a benign tumor of adipose tissue. If you've ever heard of someone getting liposuction, a lipoma is also associated with fat. These are commonly seen in adult patients and are slow growing and non-tender. These lesions are common both in the head and neck and are occasionally found intraorally. Clinically, they are soft, doughy, and yellow if close to the surface. They're treated via enucleation or conservative surgical excision and have little or no tendency to reoccur. Now, how is this similar and how is this different from our lymphoepithelial cyst? These are both benign lesions that can appear yellowish in color. They're both non-tender and usually asymptomatic, and they're both treated via conservative surgical excision if they are treated. But how are they different? Now, these are composed of adipose tissue and not lymphoid tissue and are typically not found in the tonsillar region. These are also more of a defined yellow color. They're very yellow and have a characteristic soft and doughy texture that we don't see in the lymphoepithelial cyst. These are also typically larger in size than that lymphoepithelial cyst. Next, we have a squamous papilloma. Now, this is a benign growth associated with the human papillomavirus, or HPV. Now, HPV is a group of over 200 viruses, but squamous papilloma specifically is associated with types 6 and 11, which are low-risk types for causing cancer. HPV also causes common warts seen throughout the body and venereal warts on the genitals. Oral squamous papillomas specifically are seen in patients of any age and are not sexually transmitted like other HPV growths can be. Clinically, they're usually pedunculated but can be sessile, and they're exophytic, just meaning they grow outward beyond the surface epithelium. They have finger-like projections, giving them a wart-like or a cauliflower appearance, and they usually are solitary lesions. They're soft and painless, and their color can vary between the shade of the surrounding tissue to more of a white color depending on the amount of keratin present. They're commonly found on the tongue, uvula, soft palate, and lip, but can be seen in any location. Now, how is this similar and how is this different from our lymphoepithelial cyst? These lesions do not really have much in common. They both can be found in the same area of the mouth and are both benign and maybe asymptomatic, but that's about it. Squamous papillomas are associated with HPV, and they're not a soft tissue cyst or associated with lymphoid tissue. This has a characteristic papillary or cauliflower appearance and is not a smooth surface nodule. This is also typically pedunculated rather than sessile, and it's more of a pink-white color than a yellow or red like we saw in the lymphoepithelial cyst. And last, we have a fibroepithelial polyp. Now, these are mesodermal lesions secondary to trauma, such as a sharp tooth edge or an overhanging restoration, and they're also known as a skin or mucosal tag. This lesion is actually the most common epithelial benign tumor of the oral cavity, and it's most commonly found on the gingiva, lip, and tongue, but can be seen on any mucosal surface. Clinically, they are a pink, red, or white knob-like lesion. They are small and typically asymptomatic. They're usually solitary lesions, but can be multiple and are sessile or pedunculated. Now, how is this similar and how is this different from our lymphoepithelial cyst? Now, both lesions are asymptomatic small lesions that can be sessile, but that's about it. These are not commonly found in the tonsillar region because they're associated with trauma. It's pretty hard to cause trauma in that region of the mouth. And oral lymphoepithelial cysts are not associated with trauma at all. These lesions are typically pink, red, or white instead of a yellowish red, and they're fibrous lesions instead of cysts. So we know that when we see this reddish yellow lesion under 1 centimeter in diameter that is located in Waldeur's tonsillar ring, what we are likely looking at is an oral lymphoepithelial cyst. These lesions will usually be asymptomatic, sessile, This question is asking which cells are the most affected by HIV, eosinophils, B cells, T cells, or plasma cells? Now this is a great, straightforward question, and one that could be easy points on the boards if you know this information, so let's make sure that you do. The human immunodeficiency virus is a virus that targets the immune system. This infection can be found in most bodily fluids and is usually spread via sexual contact or injection drug use. Signs and symptoms of HIV depend on the stage of infection. Initial symptoms include fever, headache, and sore throat, while later symptoms include swollen lymph nodes, weight loss, and diarrhea, and profound immunosuppression in patients with this condition can result in opportunistic infections, neoplasms, and other systemic effects. Head and neck manifestations are also very common in HIV and may even be the first sign of an HIV infection. There's no cure for this infection, but antiretroviral drugs are used to stop the virus from replicating in the body. If untreated, HIV will progress to AIDS, or acquired immunodeficiency syndrome, and this occurs when a certain cell count drops to a certain level. But what cell count does this refer to? Going back to the question, we want to know what is most affected by the human immunodeficiency virus. HIV targets the body's white blood cells, serving to weaken the immune system. The specific cell that is affected is C, the T cell, and more specifically, the CD4 T cell. CD4 T cells are also known as helper T cells, and they serve to coordinate the immune response by stimulating other immune cells. HIV attacks these cells, preventing the body from fighting off infections, and it does this by binding to the CD4 surface receptor, getting inside these cells and using reverse transcriptase to replicate. This process kills the CD4 cell, and it allows the new HIV copies to be released and to target additional CD4 T cells. A normal CD4 count for a healthy adult is 500 to 1200 cells per cubic millimeter. A low CD4 cell count is below 500 cells, and if that level gets below 200 cells, then it's classified as AIDS. I do want to point out that there are other types of T cells, such as CD8 T cells, CD4 T cells, and if that level A normal CD4 count for a healthy adult is 500 to 1200 cells per cubic millimeter. A low CD4 cell count is below 500 cells, and if that level gets below 200 cells, then it's classified as AIDS. I do want to point out that there are other types of T cells, such as CD8 T cells. CD4 T cells were the helper cells. They help out by triggering the immune response after recognizing certain pathogens and secreting signals to activate other immune cells. CD8 cells are known as cytotoxic T cells, and they are the cells that actually destroy infected cells. These cells are not directly affected in HIV, but they are affected in many chronic immune conditions such as rheumatoid arthritis, Crohn's disease, lupus, Sjogren's syndrome, multiple sclerosis, Graves' disease, and many more. But because CD4 T cells and T cells more broadly are the cell affected by HIV, we know that this answer choice was correct. Now, due to the fact that this virus does not target other cells for replication and destruction, we know that the other answer choices are incorrect. But let's still briefly discuss each one of them and talk about what conditions can affect them. We'll start with eosinophils. Now, these are a type of white blood cell that also play a key role in the immune system, especially against parasites and in allergic reactions. They also contribute to both acute and chronic inflammation and produce a variety of cytokines to help regulate the immune response. Conditions affecting these cells typically lead to an increase in their number rather than a decrease, and they include asthma, hay fever, parasitic infections like hookworms or roundworms, rheumatoid arthritis, eosinophil esophagitis, eosinophilic pneumonia, and certain drug reactions. A decrease in the number of eosinophils is typically a sign of acute infection, corticosteroid use, high stress levels, bone marrow suppression, anemia, hypothyroidism, Addison's disease, and certain leukemias. We knew that this answer choice was incorrect because these cells do not have the CD4 surface receptor that the HIV virus binds to, and because these cells are not used for the replication and dissemination of the virus. Next, we have B cells. Now, these B cells or B lymphocytes are another type of white blood cell that are essential to the immune system, especially in the body's adaptive immune response. They're derived from stem cells in the bone marrow and serve many roles, including antigen recognition and memory, antigen presentation, production of antibodies or immunoglobulins, and activation of that adaptive immune response. Several diseases or conditions can affect these cells, including autoimmune diseases like lupus and multiple sclerosis, and that's because B cells actually produce autoantibodies. They also cause immunodeficiencies and cancers and infections such as certain herpes strains. Now, I do want to point out that although HIV does not directly target these cells because they do not have the CD4 surface receptor, their function is somewhat affected by this infection. Because CD4 T cells are crucial for B cell activation, the decrease in their number will lead to less cell activation and weaken the overall immune system. But because these cells are certainly not the most affected by this infection and are definitely not used as the marker for the progression of this condition, we knew that this answer choice was incorrect. And finally, we have plasma cells. Now, plasma cells are just another type of white blood cell, and they develop from activated B lymphocytes and originate in lymphoid organs. These are end-stage immune cells that play a significant part in the humoral immune response and are responsible for secreting large amounts of specific antibodies. The class of antibodies produced and secreted by these cells depends on the signals that they receive from T cells, and they can only produce a single kind of antibody, but they can produce thousands of these per second. These cells can be affected by a number of conditions, like autoimmune conditions and infections, but the most important to know is likely multiple myeloma, which is a cancer specifically of the plasma cells. Now, just like the other answer choices, we knew that this answer choice was incorrect because these cells do not have the CD4 surface receptor and therefore are not targeted by HIV. So because they are certainly not affected in the way that T cells are, we knew this was incorrect. So when talking about HIV, it's very important to know that the cells that are most affected are the T cells, and more specifically the CD4 T cells. The eosinophils, the B cells, and the plasma cells are not affected to that extent. question is asking which is the most common site for sialolithiasis: submandibular gland, minor salivary glands, parotid gland, or sublingual gland. Now, before we talk about what the most common site is, let's talk about what sialolithiasis is, and I've attached a picture of how it presents. Now, sialo just refers to the salivary glands, and a lith is just a stone. So sialolithiasis, or a sialolith, is just a calcified structure that develops within the salivary duct. Now, this is the result of a deposition of calcium salts around debris in the lumen. The cause for these is currently unclear, but is thought to be due to either partial ductal obstructions, such as by a foreign body or cellular debris, or chronic sialodenitis, which is inflammation of the salivary gland, usually due to a bacterial infection. Clinically, these are hard submucosal masses in the soft tissue that may or may not be symptomatic. When they are symptomatic, they may have swelling or pain prior to or during meals, like when you're salivating. Now, radiographically, a soft tissue film will show these as opaque, lamellated structures. Treatment for these includes a gentle massage to milk saliva toward the orifice, medications which stimulate saliva, sour sugarless candies, increasing fluid to try and flush out the stone, or moist heat. If they are severe enough, they can be removed surgically, but the gland may be removed as well if significant inflammatory damage has occurred. Now, as for the question being asked here, these sialoliths can affect any salivary gland, but are seen 80% of the time in one gland, which would be A, the submandibular gland. The submandibular gland is the most common site for sialolithiasis. Now, let's quickly go through the other answer choices, even though we know that the submandibular gland is the most common. So, although sialoliths are more common in the major salivary glands, they certainly can occur in the minor salivary glands as well, especially on the buccal mucosa and upper lip, but they do not appear here as commonly as the submandibular gland. Next, we have the parotid gland. Once again, sialoliths can absolutely occur here, but they do not occur as frequently as they do in the submandibular gland. Sialoliths that do occur in the parotid gland can be more difficult to treat due to the fact that removing the gland would cause a lot of morbidity. Other treatment options are often attempted before surgical removal if there is a sialolith in the parotid gland, such as trying to break down the stone. And finally, we have the sublingual gland. And just to repeat it one more time, sialoliths can absolutely occur in the sublingual gland, but they do not do so as commonly as the submandibular gland. So just remember, when we're talking about sialolithiasis or a stone in the salivary duct, more than 80% of the time, they will be affecting the submandibular gland.
This question asks, what percentage of demineralization needs to occur before caries is visible radiographically? So this is an example of a PA of some anterior teeth, and we can see that these teeth are quite cavitated. So 30 to 50% of the tooth must be demineralized before it will occur on a radiograph. This is why demineralization of incipient lesions can be very difficult to detect radiographically. So with this information, option C is the best answer to this question.
We have a male, he's 30, and he says there's a swelling on the lower left side of my jaw and it seems to be slowly growing in size. We're given his medical history, social history, medications, and we notice a swelling measuring 3 by 3 centimeters seen at the angle of the mandible on the left side. We're also given a panoramic radiograph and we notice he has excellent oral hygiene. And the question asks what the most likely diagnosis is based on the radiograph. Now, since the question specifically says based on the radiograph, we know to focus in on that when we're trying to make the diagnosis. But one thing I do want to highlight in the patient box is the fact that this swelling measures 3 by 3 centimeters. That is an important detail that we'll kind of see why later on as I explain the answer choices, why it's important to note that. But we really can make our diagnosis just by looking at this x-ray. So if we look at the bottom right, which would be the patient's lower left, we see this impacted third molar and it has this well-defined unilocular radiolucency kind of enveloping the crown of the tooth. It's attached right to like the cervical area of the tooth. And this is a pretty textbook presentation and it's a lesion that we definitely want to be able to spot really quickly because it is something you'll see pretty often. And this is a dentigerous cyst. Now, the dentigerous cyst is the most common developmental odontogenic cyst, and it develops due to the accumulation of fluid between the crown and the reduced enamel epithelium. So reduced enamel epithelium is an important structure when your tooth is developing, kind of like part of the follicle, and when you have that crown and you get the fluid stuck in between, that reduced enamel epithelium will go on to become the epithelial lining that is necessary for a lesion to be a cyst. So that's what is forming this lesion. Now, clinically, we see this in the 2nd to 3rd decade, and it's usually asymptomatic. Now, obviously, that's not the case for this patient because he noticed it. He feels this slow-growing swelling, and that can happen. As the swelling starts to get bigger and bigger, it becomes uncomfortable, and a patient notices it. But notice how he's still not experiencing any pain. He just notices this swelling. Now, radiographically, we see this well-defined unilocular radiolucency, always associated with the crown of an unerupted tooth. And you can see it in this image. It attaches to that cervical area. So it always attaches to the crown like that, and it's always in an unerupted tooth. Now, it's most common in the tooth that we see in this image. It's most common in the mandibular third molar, but we also can see it in the maxillary canine, maxillary third molar, and the mandibular second premolars. Let's talk about the other answer choices, what they are, and how they're similar and different from a dentigerous cyst. So we'll start with a hyperplastic follicle. Now, this is an odontogenic hamartomatous lesion associated with an unerupted tooth, so pretty similar so far. Now, hyperplastic means more cells than normal, and follicle just means relating to the dental follicle that kind of forms and grows so we can get our teeth. Now, this is very similar to a dentigerous cyst. That's why this is kind of a tricky answer, and they're often mistaken for each other. They both are associated with the tooth exhibiting delayed or failed eruption. They look very similar radiographically, as you can see from this image. You see that well-defined unilocular radiolucency around the crown of an impacted tooth, but the key difference between the two is the size, and that's why I highlighted that detail we were given in the patient box. A dentigerous cyst is always greater than 4 millimeters in size, and you can see from that picture it was pretty big, while a hyperplastic follicle is 4 millimeters or less in size. It'll always be much smaller. Now, a hyperplastic follicle is also typically seen in a slightly younger demographic, and it's more common in the permanent first and second molars rather than the third molars. So that's how we can distinguish this from the dentigerous cyst. It's definitely the most similar lesion among these answer choices. Now let's talk about the keratocystic odontogenic tumor. Now, you might not have heard this term before, but you've probably heard of an odontogenic keratocyst. So this is just the more updated, more recent term that we use now. Now, this is a developmental cyst that can occur singularly or be associated with nevoid basal cell carcinoma syndrome. Now, for this question, we'll focus on OKCs or keratocystic odontogenic tumors as a singular lesion, just because that's what the answer choice is given. But here's some information just for reference on nevoid basal cell carcinoma syndrome. It's also known as Gorlin syndrome, and it is a complex malformation syndrome including multiple basal cell carcinomas and odontogenic keratocysts arising at an early age. So that's kind of what Gorlin syndrome is, cell carcinomas and odontogenic keratocysts, basal cell carcinoma syndrome. It's also known as Gorlin syndrome, and it is a complex malformation syndrome that occurs singularly or be associated with nevoid basal cell carcinoma. It is also typically seen in a slightly younger demographic, and it's more common in the permanent first and second molars rather than the third molars. So that's how we can distinguish this from the dentigerous cyst. It's definitely the most similar lesion among these answer choices. Now let's talk about the keratocystic odontogenic tumor. Now, you might not have heard this term before, but you've probably heard of an odontogenic keratocyst. So this is just the more updated, more recent term that we use now. Now, this is a developmental cyst that can occur singularly or be associated with recent term that we probably heard of it, a keratocystic odontogenic tumor. Now, you might not have heard this term before, but you've probably heard of an odontogenic keratocyst. So this is just the more updated, more recent term that we use now. Now, this is a developmental cyst that can occur singularly or be associated with nevoid basal cell carcinoma syndrome. Now, for this question, we'll focus on OKCs or keratocystic odontogenic tumors as a singular lesion, just because that's what the answer choice is given. But here's some information just for reference on nevoid basal cell carcinoma syndrome. It's also known as Gorlin syndrome, and it is a complex malformation syndrome including multiple basal cell carcinomas and odontogenic keratocysts arising at an early age. So that's kind of what Gorlin syndrome is, but we'll just focus on the singular keratocystic odontogenic tumor. Now, clinically, we see this being relatively common, benign lesion that can mimic a lot of other cysts. It's typically more aggressive than other cysts, and it's defined by specific histopathological features. So if you did a biopsy and looked at the histology, you would know this is what you're seeing. They're also known and kind of distinguished for having this cheesy material that kind of comes out when you're doing a surgery. So that's another way to be like, oh, okay, that's what you're looking at, which hopefully you know what you're looking at before you do the surgery, but that's another distinguishing feature. Now, these are similar because they are most common in the posterior mandible, just like the dentigerous cyst was, because that's most common in your mandibular third molar. We see this peak incidence in the third decade, which is a similar demographic. And radiographically, we see this well-defined unilocular radiolucency 80% of the time. Now, that means sometimes it could be multilocular, but it's usually unilocular, just like the dentigerous cyst was unilocular. Now, this is different because it's not associated with an unerupted tooth, which the dentigerous cyst always was, and it's not always seen attached to that cervical area of the tooth like we needed for the dentigerous cyst. This also lacks the necessary tooth association with the dentigerous cyst, similar to how we saw with the hyperplastic follicle. So that's an important distinction to be able to make. Now, finally, let's go ahead and talk about the focal osteoporotic bone marrow defect. Kind of a mouthful, but a pretty simple lesion to talk about. It's very different from a dentigerous cyst. Now, this is an area of hematopoietic bone marrow of sufficient size to cause a radiographic radiolucency. And you can kind of see it in this image. It's between the molar and the second premolar, and if you go down a little bit, you can see that darkening lesion. Now, the pathogenesis of this is unknown, but it's often seen in an old extraction site. So you can think that's probably the second molar, so the first molar was probably extracted, and that's why we're seeing this. Now, how is this similar, and how is this different from a dentigerous cyst? This is similar in that it's usually seen in the posterior body of the mandible, like we saw for the dentigerous cyst, and it's usually asymptomatic as well. Now, it's different because it's a radiolucent lesion like a dentigerous cyst, but it usually has this ill-defined border, as you can kind of tell in this image. You don't really know where the lesion starts and ends, and it's known for having a fine trabecular pattern. If you think about it, it's bone marrow, trabecular bone, like that would make sense that we're seeing this fine trabecular pattern. And it's also usually seen in middle-aged females, so a little bit older patients than we saw for the dentigerous cyst, and it's not associated with the crown of a tooth. So when we see a lesion, like we see in this x-ray, we need to be able to distinguish a dentigerous cyst based solely on the radiograph. And you'll know that by this unilocular lesion, and it's always attached to the cervical portion of an unerupted tooth, especially those mandibular third molars. This question is asking, each of the following is a hallmark sign or symptom of Parkinson's disease except one. Which one is the exception? Tremor, rigidity, bradykinesia, or mood change? Now, I'm sure you've heard of Parkinson's disease before, but you may not be familiar with all of the hallmark signs and symptoms of the condition. So let's talk about Parkinson's. This is a progressive disorder of the nervous system that begins slowly and unfortunately has no cure. Although the exact cause of this disease is unknown, it is believed there is a genetic component and possibly even environmental triggers. Risk factors include older age, hereditary, and being male. Now, this disease occurs when neurons responsible for producing dopamine start to break down or die in a specific region of the brain known as the substantia nigra. Many of the symptoms in this condition are a result of these decreased levels of dopamine, including issues with movement and irregular brain activity. Clinically, facial expressions are often limited, speech can become slurred, and there can be a loss of automatic movements such as blinking, smiling, or swinging the arms when walking. Other major symptoms include rhythmic shaking or tremors of the limbs, slowed movement known as bradykinesia, impaired posture and balance, speech changes, writing changes, and rigidity or stiffness of the muscles that can limit the range of motion. Complications include thinking difficulties, swallowing problems, chewing and eating problems, and just difficulties carrying out everyday tasks. As far as the dental impact of this disease, the tremors and other symptoms can make it very difficult for these patients to adequately manage their oral health. There are a number of helpful tips and tools out there to help these patients still maintain their oral hygiene routine, but if these are not done, then these patients often have high caries risk, gingivitis, and other oral problems. Treatment for Parkinson's mainly includes managing the symptoms, such as certain medications that can ease tremors and aid with walking and other movements. These medications are often substitutes for dopamine or work to increase natural production of dopamine by the remaining dopaminergic neurons. As the condition progressively worsens, it can be harder to treat effectively. Although this can majorly impact daily function, this condition is not fatal and most people tend to have a normal or near normal life expectancy. So now that we've discussed Parkinson's disease, it should be easy to pick out which of these answer choices is the correct answer or is not a hallmark sign of Parkinson's disease. This would be D, mood changes. Even if we didn't know this wasn't a hallmark sign of the disease, we should have picked it due to the process of elimination. Tremors, rigidity, and bradykinesia all are definitely hallmark symptoms. I do want to point out, though, that although mood changes directly are not a hallmark sign of Parkinson's like they are in other neurologic conditions, symptoms like depression are often seen in people with this condition as a result of the difficulties it presents with. So the neurological damage that causes Parkinson's itself doesn't directly cause mood changes like depression, but this is a difficult disease to live with, especially since it has no cure. So many who are fighting this disease are also fighting depression as a result. But still, this is not a hallmark symptom or sign of Parkinson's disease, so it would be incorrect here. Let's quickly go through the other answer choices and re-emphasize that they are common signs or symptoms of this disease. We'll start with a tremor. These are also described as rhythmic shaking and are often the earliest symptoms seen in this disease. You might see a little tremor in the hands, and that's where it usually starts. This is also the symptom most people seem to be familiar with when they consider Parkinson's disease, that rhythmic shaking. So it's definitely a hallmark symptom and an incorrect answer choice. Next, we have rigidity. Rigidity or stiffness of the muscles is also a very common symptom of Parkinson's disease and is one of the major causes of limited movement in this condition. This is also occur in the muscles of the face and lead to what is known as facial masking or a lack of facial expression in those with the condition. It's a very common thing in Parkinson's to see this. And because rigidity is definitely a hallmark symptom, it is another incorrect answer choice. And finally, we have bradykinesia. And finally, this would be that slowed movement we talked about. This means it may take someone with Parkinson's disease longer to do certain tasks, like standing up or rolling over in bed or buttoning up a shirt. Because this is one of those hallmark symptoms, this answer choice is also incorrect. And honestly, diagnosing Parkinson's, there is no set test to diagnose this disorder, and they'll actually look for these three symptoms, tremor, rigidity, and bradykinesia. They'll look to have two of these three to help diagnose this condition. So those three are definitely hallmark signs or symptoms of Parkinson's disease, while a mood change is not a hallmark sign or symptom of Parkinson's disease and would be the correct answer choice here. We have a 68-year-old African-American male who says my lower jaw is quite painful and my tongue is swollen. He has a cardiac stent that was placed 5 years ago. He's hypertensive. He recently recovered from COVID-19 and a skull scan was recently done at a hospital. He's taking some medications. He has a fever. He has amyloidosis of the tongue, and his lab report indicates the presence of Bence-Jones proteins. Now, what does a positive Bence-Jones protein test indicate in this patient? That's what we're being asked. And this is a pretty straightforward question as long as you know what condition is characterized by a positive Bence-Jones protein test. And that would be B, multiple myeloma. This test involves examining the urine for this specific protein, and it's found in the urine of patients with multiple myeloma in 30 to 50% of cases. Let's go ahead and talk more in depth about this condition. Multiple myeloma is a cancer of the plasma cells, and it occurs when there is clonal proliferation of one specific immunoglobulin type that is not normal or functional. Excluding metastatic disease, this condition accounts for 50% of malignancies involving bone, and is mostly seen in those over 40. Clinically, it presents with bone pain, especially in the lumbars, renal failure, soft tissue calcifications, fatigue, petechial hemorrhages of the skin and oral mucosa, fever, and amyloidosis. Radiographically, widespread lytic lesions of bone are seen as well as characteristic punched-out radiolucencies often seen in the skull, and that's what you can see in this image. Treatment serves to control the disease and keep the patient comfortable. It involves chemotherapy, a bone marrow transplant, and radiation as palliative treatment. The prognosis is pretty poor with a survival rate of typically 6 to 7 years after the diagnosis. I also wanted to highlight some other given information you could have used to get this question correct if you had forgotten about Bence-Jones proteins. Some clues that might help indicate this patient's condition would include the fact that he has amyloidosis of the tongue. The deposition of amyloid in the perioral skin and oral mucosa is common in this condition, with the tongue being the most common intraoral location for this deposition. Another clue was the fact that he had a skull scan done recently. Those punched out radiolucencies are characteristic of this condition, especially in the skull. So the fact that he recently had this skull scanned is kind of a clue. Why are they looking at this? And a final potentially helpful clue was the fact that he's an African American male. This condition is twice as common in males and twice as common in black males as white males. And it's actually the most common hematologic malignancy in black persons in the US. So although the best way to answer this question was obviously to just know what condition has a positive Bence-Jones protein test, be sure to try and use the other clues given in a question when you don't automatically know the answer. Now let's go through the other answer choices and briefly discuss what the other conditions are. We know that they're all incorrect answer choices here because they would not indicate a positive Bence-Jones protein test. We'll start with Hodgkin lymphoma. Now this condition is a lymphoreticular malignancy that develops in the lymph nodes. Any lymph node can be involved, and it presents with one or more non-tender, palpable, rubbery, firm, and enlarged lymph nodes. Hodgkin lymphoma can either be category A and present with no systemic signs, or it can be category B and present with fever, weight loss, drenching night sweats, and generalized itching. Treatment depends on the stage and involves multi-agent chemotherapy or radiation for later stages. The prognosis is fairly good, but tends to be worse for those category B patients. And once again, we know this answer choice is incorrect because it does not have a positive Bence-Jones protein test. Next, we have leukemia. Now, leukemia is a cancer of the blood cells, and there are 4 types of leukemia: acute lymphocytic leukemia, chronic lymphocytic leukemia, acute myeloid leukemia, and chronic myeloid leukemia, which each slightly vary from each other, but just for the sake of this question, we'll just focus on leukemia overall. Patients with leukemia often present with anemia, fatigue, easy bruising, increased infections, and dentally, we want to look out for diffuse gingival enlargement, which you can see in this image. Treatment includes chemotherapy, a bone marrow edema, fatigue, easy bruising, increased infections, and dentally, we want to look out for diffuse gingival enlargement, which you can see in this image. Treatment includes chemotherapy, a bone marrow or stem cell transplantation, or targeted gene therapy. And once again, we know this answer choice was incorrect because it does not have a positive Bence-Jones protein test. And finally, we have Gaucher disease. This disease is the result of a missing enzyme that breaks down lipids, resulting in these lipids or fatty substances building up in certain organs, such as the spleen and liver. There are a variety of types of this disease. It's definitely a spectrum with a variety of signs and symptoms seen. Some people may have mild or no symptoms, while others may have abdominal pains, skeletal abnormalities, and blood disorders. The condition can even cause muscle rigidity, eye movements, swallowing difficulties, and seizures. There's no cure for this condition, unfortunately, but it's typically treated via enzyme replacement therapy. And once again, we know this answer choice is incorrect because there was no positive Bence-Jones protein test indicated in this condition. So we know that when we're talking about a condition with that positive Bence-Jones protein urine test, the correct answer will be multiple myeloma. But once again, if you didn't know about this positive Bence-Jones protein test, make sure to look at the other clues. The fact that there was amyloidosis, the fact that he's an African American male, that he had a skull scan done recently, the fact that he has a fever, the fact that his lower jaw is quite painful and his tongue is swollen. So that tongue swollen is the amyloidosis. And his lower jaw being quite painful refers to these bone pains that can affect the mandible. It affects the mandible in about 30% of the time. So make sure you're looking at all of the clues, even if they're only specifically asking about one thing, because sometimes you can get to the bottom of this question, get to the answer, using other information given. We have a 41-year-old female who says, I have this jaw pain that is spreading to my ears. She has rheumatoid arthritis, severe migraines, she's taking some medications, and her oral exam shows no signs of infection, and her physical exam shows mild clicking of the jaw and pain on mandibular palpation. In the clinic, the patient reports mild jaw pain with radiation to the ears,